All right, let's dive right in. We're going to simulate a high-stakes surgical oral exam, a viva. The topic? It's a classic, an adrenal mass that just shows up out of the blue on a scan. I'm going to play both roles here, the tough examiner and you, the well-prepared candidate. Let's get started. Okay, candidate, picture this. You've got a 45-year-old, CT scan was for something totally different, and bam, there's a 5-centimeter mass sitting on the adrenal gland. The clock is ticking. Tell me your top 3 concerns right now. How you answer this first question sets the tone for everything that follows. Examiner, my thinking on this breaks down into 3 core questions. First, is it functional? Is this thing pumping out hormones? Second, is it malignant? Is this cancer we're looking at? And third, let's just confirm its origin. Are we absolutely sure this is coming from the adrenal gland? That framework is going to guide every single step I take from here on out. So, I've laid out my mental roadmap. The very next step, and you can't skip this, is to get back to basics. You have to go to the patient. It all starts at the bedside with a really good history and a focused physical exam. A good framework, I'll give you that. But now I need details. Don't just tell me you're looking for hormonal symptoms. How, specifically, are you going to question this patient to uncover them? What are the exact questions you're going to ask? Well, I'd tailor my questions to the big 3 syndromes I'm worried about. For Cushing's, which is all about cortisol, I'd ask things like, have you noticed gaining weight without changing your diet? Are you bruising more easily than you used to? For pheochromocytoma, I am hunting for that classic triad. Do you ever get sudden pounding headaches? A feeling like your heart is racing out of your chest? Or episodes of heavy sweating? And for hyperaldosteronism, I'm thinking about electrolytes. So I'd ask, have you been feeling any muscle weakness or cramping? My physical exam is going to follow that exact same logic. I'm looking for the telltale signs. Evidence of too much cortisol, like a buffalo hump, that fat pad on the back of the neck, or a classic moon face. I'm definitely going to pay close attention to the blood pressure, since hypertension is a huge clue. On the abdomen, I'm looking for those purplish stretch marks called stria. And, of course, I'll assess their muscle strength, because weakness can point straight to low potassium from hyperaldosteronism. Okay, so after talking to the patient and doing a thorough exam, I can start putting the puzzle pieces together and build my differential diagnosis. And really, it all boils down to 3 buckets. It could be a functional hormone-producing tumor, it could be a non-functional benign thing like a simple adenoma, or, the one we worry about most, it could be malignant, either a primary adrenal cancer or a metastases that's spread from somewhere else. All right, my clinical suspicion is definitely pointing in a certain direction, but suspicion isn't enough. Now it's time to back it up with hard data. We need to order the right tests, both biochemical and imaging, to get a rock-solid, definitive diagnosis. So, I just circle back to my systematic approach for the examiner. Step 1, review the imaging to be 100% sure this thing is adrenal. Step 2, order a full biochemical workup to see if it's secreting hormones. And you do this even if the patient feels fine. And step 3, scrutinize the imaging for any signs of malignancy. We're talking size, density, how it looks. Following this disciplined process is absolutely key. And then the examiner gives you this, a huge clue, a gift, really. This specific cluster of symptoms, this triad, points so strongly in one direction. My answer here has to be quick, confident, and spot on. Without a doubt, my number 1 diagnosis is a pheochromocytoma. This is a tumor that secretes catecholamines, think adrenaline, and those symptoms the patient is having, the headache, the palpitations, the sweating. That is the absolute textbook definition of the classic triad. So, to nail down the diagnosis, the best first test is a 24-hour urine collection to check for metanephrines. The reason we do a 24-hour collection is because these tumors can release hormones in bursts, so a single blood test might miss it. This test is the gold standard. It's about 98% sensitive and 98% specific. It's incredibly reliable. So once the lab tests confirm we have a pheochromocytoma, we have to pinpoint its exact location. That's where imaging like a CT or MRI comes in. You can see from this image just how complex the adrenal gland's anatomy and blood supply is. Knowing precisely where that tumor is and what vessels it's near is absolutely crucial for planning a safe operation. Okay, so we've confirmed it's a pheochromocytoma, and we know where it is. Now we get to the most critical phase of all, management. I'm telling you, taking a patient with this tumor to the operating room without the right preparation is a potentially fatal mistake. The preoperative prep is non-negotiable. And the sequence is everything. First things first, you start an alpha blocker. This controls the blood pressure and gives the patient's blood vessels time to relax and expand. This takes about 1 to 2 weeks. Then, and only after you have them properly alpha blocked, you add a beta blocker to control their heart rate. Finally, you load them up with fluids to make sure that newly expanded vascular system is full. This prevents their blood pressure from crashing after the tumor is removed. Let me just say this again, because it is that important. Starting a beta blocker before an alpha blocker is one of the most dangerous things you can do. It can cause what's called unopposed alpha stimulation and send their blood pressure into the stratosphere. Alpha blockade always, always, always comes first. There are no exceptions. Now for the surgery itself. The approach we take really depends on the tumor. For our 5-centimeter mass with no scary features, a laparoscopic or keyhole adrenalectomy is the way to go. It's minimally invasive and the patient recovers much faster. But if you're dealing with a big tumor, say over 6 centimeters, or if you have any inkling it could be cancer, you've got to do an open operation to make sure you get it all out safely. Inside the OR, it's all hands on deck. The anesthesiologist needs invasive blood pressure monitoring, like an arterial line. The surgeon's mantra has to be, handle the tumor gently. The less you touch it, the less adrenaline it squirts out. And here's the single most important surgical step. You have to tie off the main adrenal vein first. That's what cuts off the hormone supply to the rest of the body. The whole team has to be ready for wild blood pressure swings, sky high 1 minute and dangerously low the next. And there you have it. That's our simulated viva. The candidate has navigated a really tricky case from start to finish. So let's step back and boil this all down to the absolute high-yield takeaways. These are the points that will help you ace any exam on this topic. These are the absolute landmines, the red flags. Starting a beta blocker first is a critical, dangerous error. Not preparing the patient properly with medical blockade is just as bad. Forgetting to check if any adrenal mass is functional is a huge miss. And in the OR, not getting that adrenal vein early or not being ready for the blood pressure roller coaster, that shows you just don't understand the physiology of this disease. And what about those non-functional masses we talked about way back at the beginning? For those, it pretty much comes down to one thing: size. The general rule of thumb is that any non-functional tumor that's bigger than 4 centimeters should probably come out, just because the risk of it being a silent cancer goes up with size. This quote really says it all. This is the whole ballgame for the surgeon. You need precision, you need to be gentle. Your goal is to get the entire tumor out in one piece without breaking it open and spilling its contents, whether that's a flood of hormones or a bunch of cancer cells. And now for one final thought, a real curveball from the examiner. The surgery is over, the tumor is in the bucket, but the patient's blood pressure is still high. What's going through your mind now? This is next level thinking. Are you considering a second hidden tumor? Could there be metastatic disease? It's a tough question and a perfect way to end a discussion on a really complex problem.